Hi, everyone. So nice to see everyone. Hopefully you have beautiful weather, just like we do here in Baltimore. I am happy you're all here with us today. So thanks for joining us and welcome to this afternoon's program. I'm Jamie Seward, Associate Director of Affinity Engagement Programs with the Office of Alumni Relations. Before we proceed, I'd like to acknowledge our co-sponsors, the Department of Neurology and Brain Sciences and the Healthcare Affinity. Now, before I turn the program over to our speaker and our moderator, I encourage you to ask questions by typing them in the Zoom Q&A located at the bottom of your screen. Now, I have the pleasure of turning the program over to our moderator, Rachel Ermer. She's the Assistant Director of Development, Department of Neurology and Brain Sciences. Rachel?
Thank you, Jamie, and thank you to everyone joining us today. Dr. Gold is an associate professor of neurology here at Johns Hopkins and has training in neuro-ophthalmology and in neurovestibular disorders. He sees patients with neuro-ophthalmic and autoneurologic vestibular disorders. He is passionate about patient care, leading a novel TeleDizzy consultation practice, in addition to having a busy outpatient practice. Thank you for joining us today, Dr. Gold, and I'll turn it over to you.
Thanks so much. Let me share my screen and get started. All right, and hopefully this can be seen. If not, please somebody let me know.
It looks perfect.
Okay, great. All right, thanks so much for joining on this beautiful afternoon. Hopefully people are watching this outdoors and getting some vitamin D. Again, thanks for being with us for this hour. I've got my son is outside right now in his recess from virtual school. My daughter is in actual school and my wife is at work. So hopefully everything is stable and unremarkable for the next hour. If I look over at my phone and look alarmed, it's probably because her school's calling. So please excuse me. So I'm going to be talking about telemedicine, TeleDizzy. I'll explain what this means and what these services are, what we've done using telemedicine before the pandemic, as well as in the midst of the pandemic. Before we get started, I just wanted to tell you about a monumental achievement that happened just this morning. I created this. I've mastered espresso making and steaming milk, and now I've moved on to latte art. So I was just very proud of myself. It's been a tough year, so you got to appreciate the little things. All right, I have no disclosures. This has really been a tremendous team effort. Lots of people in neurology and our division of neurovisual and vestibular disorders, including Dr. David Z, Dr. David Newman-Toker, as well as colleagues in emergency medicine. Io McClenny has been excellent. Everyone here has been great. It's really been a team effort. I just wanted to say a special thanks to the donors who are here, any donors to our division. You are really part of this team too, and your generosity has made these services possible for other patients. So we really do appreciate that. So I'll be talking about a TeleDizzy consultation service. What is it? What have we found? What's good? What's bad? A little bit about virtual sort of telemedicine clinics in the COVID era for dizzy patients and some next steps. Where do we go next? So first, TeleDizzy in the emergency department using video oculography, these VOG goggles that record eye movements. So first, why dizziness? Why should we care about dizziness? Why should doctors care about dizziness? Why should patients care about dizziness? Missed stroke is a leading cause of misdiagnosis-related harms. The dizziness is most tightly associated with missed stroke, which is not at all surprising for any clinician, any physician out there who deals with dizziness. It is a tough symptom to evaluate. Diagnostic error rates in acute dizziness in the emergency department in particular, is really, really high. With vestibular disorders, about 80% diagnostic error rate. Stroke is about 35%. The point here is that dizzy experts diagnose patients based on their eye movements. We look at jiggly eyes all day, and when the eyes aren't jiggly, we try to make them jiggle, and that tells us what's going on when the eyes are moving, like this guy's eyes. And so if this patient comes into the emergency department with acute onset, continuous dizziness or vertigo, I'm going to use those two terms, dizziness and vertigo, sort of interchangeably, and the eyes are jumping like this. Dr. David Newman-Toker has written about this at length. This three-step eye movement exam called HINTS, which we'll go into, is far better in the hands of subspecialists than even getting an MRI in the first 24 or 48 hours. The key here is that in the hands of subspecialists, we don't know how non-subspecialists really fare in the emergency department. So patient one, this patient is another one who has the acute vestibular syndrome, meaning that, again, relatively abrupt onset, continuous dizziness or vertigo, nausea and vomiting, nystagmus is the term for these jiggly eyes. The patient's off balance, they can't move their head, they don't want you to move their head. This is the acute vestibular syndrome. In this kind of patient, about 80% of the time, this is a benign problem. This is an inflammation of the balance nerve, the nerve that connects the ear to the brain, sort of akin to a Bell's palsy. These patients don't need to be admitted. These patients can go home and be managed conservatively. But about 20% of the time, this is due to a potentially dangerous problem like a stroke. And again, this HINTS exam, the eye movement exam, is really what we use, what we must use to distinguish one from the other. And it works well in the hands of subspecialists. So what's the right test for that patient who comes into the emergency department with continuous symptoms, whose eyes are jiggling? It is definitely not the CAT scan. The CAT scan misses about 90% of acute vestibular strokes. The MRI is far superior, but still, we think that in the first 24 to 48 hours, it's probably missing up to 20% or so of little strokes in the cerebellum and the brainstem. The HINTS exam is what we should be doing for those patients with the acute vestibular syndrome. It's much better than both. It has a sensitivity for detecting a central etiology like stroke of 96.8%. It has a specificity for detecting a central etiology like stroke in that patient of 98.5% in the hands of subspecialists. So what is the HINTS exam? I've just talked about it quite a few times in a few slides. So the HINTS exam is the head impulse. This is the head impulse test, moving the head quickly from one side to the other. This is an evaluation of what we call the vestibulo-ocular reflex, the balance reflexes, which keep the patient's eyes stable when the head's in motion. So I can move my head quickly to the right, my eyes go sort of equally and oppositely to the left. I move my head to the left and they go to the right. That is the vestibulo-ocular reflex at work that allows you to walk down the street with each footstep. You can keep your eyes stable on whatever it is you're looking at, whether that's a street sign in front of you, whether that's a familiar oncoming face. That's the head impulse test. An abnormal head impulse test is when we see that the eyes move with the head for a split second, and then we see this catch up. So everything's easier in slow motion. Here we see head movement to the right, the eyes go with the head to the right, and then there's a catch up movement. That's the catch up movement. That tells us that there's an abnormal head impulse or a catch up saccade to the right. We're looking for nystagmus. That's the N in the HINTS exam, the jiggling eyes. This patient's eyes are jiggling to the left, and everywhere he looks, they're still jiggling to the left. Much more when he looks to the left. As you can see now, they're more jiggly. And this is the test of skew, looking for a vertical deviation. And here we see that every time the hand is moved from the right eye to the left eye, there's no vertical movement. All of these must be present and look peripheral or look reassuring for us to be able to diagnose a benign condition like vestibular neuritis with certainty. This is what we need to do. But when we see this combination of signs of exam findings, it's almost always a benign etiology, almost always peripheral. What about the HINTS exam in a stroke? So the head impulse is oftentimes normal. In this situation, the head's moved quickly to the left or to the right, and the eyes stay right on the target. Nystagmus, you can see different patterns. So here we see that it's actually vertical. The eyes are jiggling vertically. There's a slow phase down and a fast phase up, and a slow phase down and a fast phase up. Here the patient's looking out to the right, and the eyes are right beating, looking to the left, left beating. That has changed direction. That is bidirectional. That is gaze evoked. They all mean the same thing. This is a central pattern. Finally, the test of skew, we're looking for a big vertical movement like this. So the right eye comes way down, the left eye comes up, the right eye comes way down. This is abnormal. This is a skew deviation, and this is highly suggestive of a central or dangerous problem. In this situation, if any of them look central, then everything should be considered central until proven otherwise. Patient 2, positional vertigo. A patient has, when they roll over in bed at night, to the right or to the left, when they look up, they look down, when they go from lying to sitting or sitting to lying, all of a sudden there's 30 to 60 seconds or less of spinning vertigo. This positional vertigo is almost always indicative of benign paroxysmal positional vertigo, which is extremely common. So what we do is this Dix-Hallpike maneuver. The patient's head is moved about 45 degrees to the right. He's seated, and then we move him down, and then we look at the eyes. The patient, this will provoke the symptoms of vertigo. This will cause the eyes to jiggle. This nystagmus is very predictable. And we can say with 100% certainty, this is right posterior canal benign paroxysmal positional vertigo. And this is exactly the repositioning maneuver we can do to treat that. So the HINTS exam and the Dix-Hallpike work, and they work really well. And there's a lot of literature to support their use if exam maneuvers are applied appropriately. So in the right patients. So we do the HINTS exam for acute vestibular syndrome. We do the Dix-Hallpike exam or maneuver for BPPV. And if they're properly performed, that HINTS exam takes a lot of time and effort to sort of develop those psychomotor skills associated with the maneuvers themselves. And then it takes additional time to really understand what they look like, what they should look like, what happens when they're abnormal, and interpreting. What does that mean? So if the results are interpreted correctly, this is a peripheral HINTS, or this is right posterior canal, BPPV, it works really well. But commonly, especially in the emergency department, exam maneuvers are applied in the wrong patient populations inappropriately. So HINTS in BPPV, that's not what we should be doing. Or the Dix-Hallpike in the acute vestibular syndrome, these patients will throw up on your shoes, but that's not a positive test. Or the maneuvers are improperly performed, especially the head impulse test. That takes a lot of practice to get good at. Or the results are misinterpreted. Those are the problems. So what have we been doing with a TeleDizzy consultation program in the emergency department? We've been simply having, because the HINTS exam works so well, because Dix-Hallpike works so well, we've been having a technician go down to the emergency department, put on a pair of these video oculography goggles and record eye movements. And we can see the eyeball, there's a camera mounted over the goggles over the right eye. We can see a room camera to understand the head and body position of the patient. Unfortunately, the room camera wasn't turned off for this particular patient. And I can look at this eye movement for 5 seconds or less and say, with a very high degree of certainty, that this patient who has the acute vestibular syndrome is having a stroke or is having something dangerous happen to their brain. This is not compatible with a peripheral or benign vestibular neuritis. In this situation with TeleDizzy, the exam is applied appropriately. It's properly performed by a trained technician with recordings, and the results are interpreted by a subspecialist expert. And I can say, again, within 5 seconds, this is a stroke. So the technology is there. We have these portable video oculography goggles. And again, it's small enough to be able to do this in the emergency department. We just simply need a trained technician. We need the goggles. We need a laptop computer. That's it. That is the rationale for a TeleDizzy service. So what is TeleDizzy? What's the workflow? The dizzy patient comes into the emergency department. The emergency provider evaluates for any obvious medical causes or stroke. If this looks like a stroke or could be a stroke, or if they're potentially in a window where they might get a thrombolytic agent, we don't want to hold up that process. We want neurology to be called right away to evaluate to see if they are a candidate, if this could be a stroke. But if it's not obviously medical, it's not obviously neurologic, we want to be called if your suspicion for something central or dangerous was still high enough that you would have normally ordered a scan, which is almost always a CAT scan, which, as I showed on a previous slide, is almost never helpful in this kind of circumstance. So we need a technician, we need the goggles, we need the software and a laptop computer. And we do a standard battery of eye movement and vestibular tests. And so what does this consist of? We simply have a recording of the eyes looking straight ahead, looking to the right, left, up, down. Again, if there's any jiggling of the eyes, nystagmus straight. If there's any jiggling to the right or to the left, that can help us. That's part of the HINTS exam. Instead of the head impulse test, there's a video head impulse test, which I'll show you what that looks like. And a test of skew. Then we put the patient in the dark and we do the same thing. So another recording of the eyes, straight, up, down, left, right. We shake the head around a couple of times, not to torture patients, but because it can be diagnostically helpful. We perform the Dix-Hallpike maneuver. We perform the supine roll, which is looking at BPPV in one of the other canals, not the posterior canal, as well as the bow and lean test, which can help to further localize where the problem could be. So why do we do these things? This is the HINTS exam. This is exactly what I just showed you. This is sort of the VOG HINTS exam. Why do we put the patient in the dark? Because that helps us to see vestibular nystagmus, jiggling of the eyes. Why do we shake the head? Because there are well-known and recognized central and peripheral patterns that can help us identify whether this is an ear problem or a brain problem. Why do we do Dix-Hallpike and supine roll? This is to diagnose the most common forms of BPPV in these various canals. So what does it look like? So getting back to, we have the video head impulse trace. We have the jiggling of the eyes. We can see the traces here, almost like an ECG of the eyes. We have a dizzy questionnaire. You have to put the exam, the findings into some kind of clinical context. So we have a questionnaire. There's some asynchronous review of all these materials in addition to usually a synchronous teleconsult with the patient. There's almost always another question or two to be asked just to make sure that nothing else is being overlooked. And in doing so, we're able to categorize patients, kind of put them into three buckets. One is the red light bucket. This looks dangerous. This could be a stroke. These patients need neurology involved in their care. They need an MRI. They need an MR angiogram. That's one bucket, which is oftentimes pretty obvious. Another oftentimes pretty obvious bucket is the green light bucket. These are the patients with BPPV. This is not a problem that needs to be admitted into the hospital. These patients don't need a CAT scan or an MRI. They need their BPPV treated. Or vestibular neuritis is another problem that can be managed conservatively at home. Other patients fall into this sort of ambiguous yellow bucket where we have been following up with them expeditiously in sort of an urgent outpatient clinic to try to better understand what's going on and how we can help them. That has been the workflow. So what about BPPV? I showed you an example earlier. Here's again the characteristic right Dix-Hallpike, right posterior canal BPPV. This is what it looks like at the bedside. This is what it looks like with TeleDizzy. So here you can see the room camera, where you can see that the patient's lying down. The Dix-Hallpike maneuver has just been performed. You can see the jiggling of the eyes here. You can see on the traces that vertically the eyes are moving and jumping. It's crescendo, decrescendo. There was a latency of a couple of seconds. It's upbeat torsional. This can be nothing other than posterior canal BPPV. This patient can be hopefully treated before he goes home. But this patient does not need to be admitted. They do not need the unnecessary radiation of a CAT scan, for instance. What about right horizontal canal BPPV? This is the supine roll maneuver. So now the crystal's not stuck in this canal, the posterior canal. Now it's stuck in the horizontal canal, which is the second most common. So we see now the eyes are moving horizontally. There's nystagmus. And now it's moved to the left side, and there's a lot more nystagmus. So this is horizontal canal BBBV. How do we see it with the VOG, with TeleDizzy? In this situation, the right ear is down and the eyes are jiggling to the right. There's right beating. Now the left ear is down and there's left beating nystagmus. I can say with a very high degree of certainty here that this patient has right geotropic horizontal canal benign paroxysmal positional vertigo. Here's how to treat it. This patient does not need to be admitted into the hospital. What about vestibular neuritis? What does the HINTS exam look like? So I mentioned it's a video head impulse test. So here we can see not only those catch-up movements that we saw at the bedside, seen as these red lines here, these are the corrective saccades, but also the software calculates a gain. So if I move my head to the right, my eyes should move equally and oppositely. And if the gain, the output, the eye movement matches the head movement, which is the input, the gain should be calculated as pretty close to 1 as it is to the good side, 0.9. To the bad side, it's 0.49. So this gives us multiple measures to tell us that there's a hypofunction, a problem with that vestibulo-ocular reflex, the balance reflex on the right side, but not the left side. We can look at the nystagmus. Again, we can look at the traces, we can look at the video, and we can see that in all directions of gaze, this patient has left beating nystagmus. We can also have our technician cover the right eye and then cover the left eye and then the right eye and then the left eye and the right eye and the left eye, looking to see if there's any vertical movement here on this vertical trace, and there's not. So this is compatible. Abnormal saccades to the right, corrective saccades, abnormal head impulse, and unidirectional nystagmus, and a normal test of skew. This is highly suggestive of right vestibular neuritis. So what are the challenges? And there are challenges. This is our technician performing a video head impulse test on a patient with the acute vestibular syndrome in the emergency department. And he's very gentle. You can see it's a very small movement of the head. Patients really tolerate this quite well. And he's really good at it and makes it look really easy. So people need to be trained to do this. The good news is that the software gives immediate feedback. That head impulse was too slow. You went too far on that one. So this feedback is great, but technicians need to be trained. Skills need to be monitored. They need to be signed off on, and there has to be some sort of maintenance of skills involved as well. Fortunately, Dr. David Newman-Toker has demonstrated that novices, somebody who's never done this, can be trained to sort of up to sort of expert status over the course of a couple of hours with 200 to 250 or so repetitions of just doing these head impulses. And people can get quite good at it. So it is entirely possible to train people to do this who have no idea what the vestibular system is, who have never evaluated or seen a dizzy patient in their lifetime. People can be trained to do this. Challenge number 2, not every patient's a great candidate. Some patients have difficulty keeping the eyes open or blinking too much. This patient was too blinky. This one was too sleepy. If we can't see the eyes, we can't do the eye movement based TeleDizzy consultation, unfortunately. Challenge number 3 is that the goggles only evaluate the eye movements. So I wish we could strap the goggles onto the arms and legs and evaluate motor function and sensory function and coordination and everything else, but the goggles can't do that. So somebody has to examine the patient. Somebody has to see that they can walk by themselves. Somebody has to evaluate their reflexes and their coordination and their motor strength, their motor function and their sensation. Patients can come in with a TIA, a transient ischemic attack, that's causing dizziness or vertigo. But by the time they get to the emergency department, they're asymptomatic. So the goggles are going to be normal, probably, in those patients who are completely asymptomatic at that time. So these patients, everyone needs a history. People have to ask the questions. We have to risk stratify. We have to understand Do they have high blood pressure, diabetes? Are they a smoker, for instance? What about a patient with a stroke that's causing a balance problem or dizziness and normal eye movements? This can happen as well. But again, these patients normally have difficulty sitting independently, or they have severe gait ataxia or severe imbalance. They can't walk independently. That's a big red flag. So again, somebody else, somebody who's there, needs to evaluate these patients. What about a patient who has a peripheral Hintz exam and acute deafness? This can happen. There's something called labyrinthine. This is the labyrinthine ischemia. So the basilar artery supplies the anterior inferior cerebellar artery. And the basilar artery, and these arteries are the same that are supplying blood to the cerebellum and the brainstem, the balance parts of the brain, to the internal auditory artery. So you can have a stroke that involves the ear. So if a patient has a peripheral looking Hintz exam, but has gone deaf in one ear, that is also very concerning. So somebody needs to look in the ear. Is there an infection? Is there labyrinthitis? Are there vesicles that might suggest a zoster infection, for instance? So again, the goggles can't do everything. So what have we found? So since July 1st, 2017, Monday through Friday, normal business hours at the pilot hospital site, JHH, this is what we've found. Here have been the successes so far. So the diagnostic yield, compared to a baseline population, the baseline population of ED patients presenting with dizziness or vertigo, 21% of those patients received a specific vestibular diagnosis. With TeleDizzy, 57% of them have. The vast majority of those have been BPPV, but many of them have been vestibular neuritis, vestibular migraine, Meniere's. So we can make these diagnoses with TeleDizzy. What about stroke? The baseline stroke rate in these patients is about 0.3. It's much higher with our population because, again, by definition, we want you to consult us if your suspicion for something central or dangerous is high enough that you would have gotten a scan. What about non-diagnoses? So a lot of patients leave the emergency department with a symptom code of dizziness or vertigo, which is not an actual diagnosis. That's just the symptom. With TeleDizzy, we were able to cut that in half. About 30% of the patients sort of leave, or we are only able to say that they have dizziness or vertigo for unclear reasons. We can't diagnose every single patient based on one single sort of limited encounter. What about imaging? The baseline rate, about 49% of them are getting a CAT scan. We've recommended CAT scans in about 2% of patients. And MRI, when we have a suspicion for something central or dangerous, we always recommend MRI and almost never CAT scan. But the base rate, the MRI rate, is about the same here. So we're not just simply taking all of those would have been CAT scans and turning them into MRIs. So we're still saving money on unnecessary testing. And fortunately, none of those patients who we've performed a TeleDizzy consultation on have returned with a stroke, which is good news, which probably means that we're getting the diagnoses right in those cases, and we're able to identify those patients who probably have a dangerous cause for their dizziness. Other advantages of this unique service, and again, nobody else out there is doing anything like this across the country, across the world. So patient care, we're getting the diagnosis right acutely in a large number of patients. We're preventing costs, both financial and personal, associated with unnecessary consultations and testing, with misdiagnoses, with diagnostic delays. We can begin to treat a lot of these conditions immediately. They have vestibular migraine, let's treat for migraine. They have a stroke TIA, let's get them plugged in with the stroke service ASAP and see why that's happened. Vestibular neuritis, there are things we can do, getting them started with vestibular physical therapy. Meniere's, BPPV, we can cure. Sometimes with a single maneuver in the emergency department. Oftentimes it requires more than that, which is why we have close ties to our vestibular physical therapy colleagues, and we're able to get them in with them expeditiously. Again, this is really a team effort. Education. This has been excellent training for our ocular, motor, and otoneurology fellows. This has been great. This is a very unique experience. It's also been great for the neurology trainees and the neurologists and emergency medicine providers. We're giving them real-time subspecialist feedback. You said that this was abnormal, but actually it's normal, and here's why. So this has really been a great experience for not just neurologists, not just our fellows, but kind of everybody who's involved in the care of these patients. So what about outpatients? What about virtual vestibular ocular motor clinics in the COVID era? So some things work really well, and it's been a lot of trial and error, and sort of at the beginning of the pandemic, everyone kind of just fell off the cliff of telemedicine, and nobody really knew what to do. Nobody really knew what worked, what didn't work. But here's what I have found to be helpful. So there are ways to be creative and gain a lot of information about the patients, a lot of information about their eye movements. Some things work really well. Checking, using an app, putting it up to the camera, having the patient follow it with their eyes, the optokinetic nystagmus, this works really well. This is highly effective, in my opinion. Also, using a spoon. The spoon has been one of my best friends. You can use the spoon to cover each eye. You can use a spoon for temperature sensation on the face and arms and legs. So again, we've had to be creative, and it's been kind of fun figuring out what works and what doesn't work over the months. What about the Dix-Hallpike maneuver? We can easily do this at home. We can do it safely. Patient can be on their bed or on the floor so they don't topple off of something. And we can make this diagnosis, which is a very, very common diagnosis at home and in the emergency department, of BPPV. We can also do it sort of a modified chair Dix-Hallpike as well. If there's an issue with getting somebody down to the floor or down to their onto their bed, assuming that somebody has arms on the chair and they're unlikely to fall out of the chair. And we can make these diagnoses of posterior canal BPPV. We could even send patients handouts with, you have left BPPV, here's the left Epley maneuver, this is how you do it. And patients can cure themselves. Other things don't work so well. For instance, this is the head impulse test. Here's another example of an abnormal head impulse test where our technician is moving the head quickly to the right and to the left. And you can see this corrective movement of the eyes. That's an abnormal head impulse. In this case, it's abnormal to both sides, but more so on the left side than the right side. This is great. This is unpredictable. The patient doesn't know where the head impulse is going, and this is highly effective. And this is a normal person who doesn't have any vestibular pathology. And you're just simply asking them to move the head to the right, move the head to the left. It's not, the patient can sort of predict what's going to happen, where their head's going to wind up. This doesn't work so well, even in a patient who has pretty significant vestibular loss. And remember, this is the head impulse test. This is a very important piece of the HINTS exam. So this really limits our ability to evaluate patients with that acute vestibular syndrome at home. So this by itself is not adequate. Conclusions from all this. So lessons, what have we learned in the ED via this TeleDizzy consultation service? With TeleDizzy, we can achieve a greater diagnostic accuracy, lower utilization, less radiation in the form of CAT scans. But when a patient needs to be imaged, when we see something that doesn't look good, we can recommend the right test, which is the MRI. Barriers do remain: training, billing issues, funding, staffing for 24/7 service. Up to this point, it's been sort of me Monday through Friday, 8 to 5. So in the future, this is going to be a 24/7 service. Lessons learned in the virtual clinics. The history is extremely important, even more so in the virtual world, because there are some limitations in the exam. Adding a focused vestibular, ocular, motor, and neuro exam is adequate for the vast majority of patients. But what we've been doing is sort of a hybrid, having patients come to the clinic to see our technician who's using that same video oculography technology to do everything else we need to do. The combination of taking the history virtually, doing whatever elements of the exam we can do virtually, plus an in-person component to do this dedicated eye movement vestibular testing has been really highly effective in the COVID era. Next steps from an ED standpoint, expansion to other hospitals. At home, we're in the process of leveraging app-based technologies. So in the not too distant future, instead of this, what we're calling TeleDizzy portable, where we're in the emergency department with this laptop setup and the video oculography goggles, how can we bring this into the home? Well, we can do a lot of the exam. We can do a lot of the hints exam. We can do Dix-Hallpike. We can record a lot of these eye movements with a smartphone. The technology is there. So we are in the process of utilizing this technology with some sort of software upgrades and creativity to try to figure out how to triage these patients from home, and how to instruct patients to download some software and record some eye movements from home. In doing so, we could easily identify this is BPPV. This patient can stay home, or you know what, this looks like vestibular neuritis. This patient doesn't need to go into the emergency department, especially in the midst of a pandemic. Or you know what, I'm not sure what this is. I'm a little concerned. Let's have them come into our urgent outpatient clinic expeditiously for further evaluation. Or you know what, this looks concerning. This patient needs to go to the emergency department, where they may be a candidate, or we may be able to do this sort of complete battery of eye movement testing with our more expensive video oculography goggles. So that's where we're going. So the future is bright. The future is exciting. Thank you so much for your time and for your attention. If anybody's interested in any of the videos that I showed and lots more educational content, I also have my own eye movement collection through the North American Neuro-Ophthalmology Society. Thank you so much.
Thank you so much, Dr. Gold. I think we have some questions, so I'll read those. Is Dix-Hallpike the same as Epley's?
So the Dix-Hallpike maneuver is the diagnostic maneuver to, that's how we can diagnose BPPV. Once we've diagnosed BPPV, we then oftentimes will use the Epley maneuver to treat it.
Next question, is there a connection between peripheral neuropathy and episodic dizziness?
So not usually. There can be. That's a bit of a complicated question, not knowing more about the clinical context, but not generally. Usually if somebody has a peripheral neuropathy and episodic dizziness, the two are unrelated, but I can't say that about every case.
Okay, do you have tips for those of us doing telestroke consults on dizzy patients without VOG or trained subspecialists at remote ED locations?
Yeah, I mean, that's tough. Like I just showed, you can look at the nystagmus over sort of FaceTime works really well. I can say this is unidirectional nystagmus. This is sort of a mixed horizontal torsional right beating that increases in right gaze, and this looks peripheral. Or if it's clearly central, I can say that this patient has upbeat nystagmus. That's definitely not peripheral, that's central. That is one piece of the HINTS exam. You can easily check for ocular alignment by having somebody just simply do this, look at a target across the room. So that's two pieces of the HINTS exam, but the head impulse test is really the challenging one. and you would really need somebody on the other end performing that, who knows how to perform it. Somebody needs to be there who knows how to interpret that test. And unless you're really sure, then you're going to sort of err on the side of caution. And if nobody can prove that it's vestibular neuritis, probably going to wind up imaging some of those patients.
Okay. Is dizziness over an extended period, for example, days or weeks, always BPPV?
Right. So BPPV is a problem that typically only causes symptoms for 30 to 60 seconds or less after it's triggered. So somebody rolls over in bed, they look up, they look down, they go from lying to sitting or sitting to lying. Symptoms are triggered. Those crystals sort of settle to a different part of the canal with gravity. The symptoms subside until the head is moved again. But generally in between, people with BPPV should feel pretty well. So if there are constant symptoms for minutes or hours or days, that is incompatible with BPPV. Fortunately, those crystals usually just through sort of normal living will work their way out of the canals where they shouldn't be. So if you do nothing, usually they go away over the course of days or weeks. Sometimes they can get stuck there for months or sometimes years if nobody performs that repositioning maneuver. But this is really a very short-lived episodic disorder for sort of attacks lasting less than 30 to 60 seconds usually. And in between, you should feel pretty fine.
We have a question from a patient with vestibular migraines asking if there's a way to get a virtual visit if she were in the middle of a vertigo episode.
Right, so that's been a huge advantage to sort of the technologies now available to us. Logistically, it's always been a huge challenge. If somebody has episodic dizziness or vertigo, you want to know what's happening in the midst of their attack. And so I always talk to patients, can you take a video of your eyes at home, or is there some way that we can connect virtually? Unfortunately, there was no easy way to connect via FaceTime or to connect via one of these video platforms until the beginning of the pandemic. Now there are a ton of different platforms that we can use to connect with patients to see what's going on in the midst of an attack. So absolutely, that's been a huge advantage to sort of how ubiquitous telemedicine has become.
Great. Have you seen an increase in dizziness or vertigo during the pandemic? Has the increased use of Zoom and video conferencing created an increase in these symptoms in patients?
Right. So as far as COVID and dizziness, so dizziness, there are many sort of non-vestibular causes for dizziness and vertigo as well. So we always need to think about those. A lot of patients have been sort of reported with kind of the long hauler or the long COVID kinds of symptoms. Dizziness has been a part of that constellation of symptoms, and some of those reported. We don't have a great understanding of what's going on. For us personally, I mean, at JHH, the volumes of patients overall really dropped. The volume of dizzy patients coming into the emergency department, those, for instance, with BPPV who might have come before the pandemic, people's threshold is sort of much higher to come into the emergency department. So the volumes of dizzy patients in the emergency department really plummeted. They're beginning to sort of get back to where they were. But I would say COVID-related dizziness, we don't fully understand what's going on. We will have a better understanding in the coming months of what might be the root cause or a root cause. But I have seen very few patients with complaints of dizziness thought to be due to COVID or in the setting of COVID. It's been a lot of patients we've seen virtually who maybe were infected with COVID a couple months ago, but kind of has nothing to do with their symptoms now.
Mm-hmm. Will ED physicians at other hospitals see the value of taking the time to perform these tests on dizzy patients?
Right. So I think that they see the value of this, especially in the JHH ED. They see what we do and they really appreciate it. And in surveying them consistently, sort of one of the most common pieces of feedback we get is, can you please do this after hours and on weekends, because they really appreciate the service. So they appreciate it, but like I said, it's difficult, and it takes time and it takes effort to learn how to perform the maneuvers, to learn how to interpret the maneuvers. And unfortunately, it's not really part of their training. Unfortunately, it's not really part of neurologists' training at many institutions as well. So we're trying to change all of that.
Well, I think that was our last question. So thank you so much, Dr. Gold. And I'm going to hand it over to Jamie for some closing remarks.
Hi, thank you so much. I excuse the barking dogs if they decide to overact right now. They're very excited about your program. It was excellent. And we appreciate all of you for joining us this afternoon. And Dr. Gold and Rachel, you've done a great job. So a follow-up email will be shared with everyone who attended today's webinar. It'll include the recording of the program along with a list of resources and our event schedule. And we hope you will join us at a future program. So with that, thank you so much. Have a wonderful day. Stay safe, stay healthy, and we'll see you soon.
Thank you.